Hi, I'm Jen DeYoung, United States of Care's Director of Policy leading up our Building Blocks of Health Reform initiative. Thanks for checking out United States of Care's video on equity in virtual care. In 2020, we've seen the COVID-19 pandemic response unleash a revolutionary expansion in virtual care, whether it be telehealth, remote monitoring, or other remote forms of communication. Virtual care tools are shiny and new for many, but at United States of Care, we're looking beyond the present to the potential it has for being a long-term lasting solution to close gaps, address barriers, and get more people access to the care they need. To do that, we're starting with people and taking time to listen to their experiences with virtual care. What's working, what's not. For example, we fielded a national poll in November 2020, and we know from that there's wide support for the convenience of virtual care, especially during the pandemic. However, many people have questions about the accuracy of care and concerns about the use of technology. We're continuing to listen to people and pairing what we hear along with what the research evidence and experts know so we can see what's needed as virtual care policies are formalized and practices are refined to ensure we create a virtual care system that works for everyone. I'm excited to share with you today perspectives on virtual care from some of the healthcare leaders who are partners in guiding our work. In this conversation, you'll hear from
My name is Abner Mason, and I'm founder and CEO for ConsejoSano.
My name is Frankie. I am a care coordinator with ConsejoSano.
Thanks to Abner and Frankie for sharing their voice. Enjoy.
So again, I'm Abner Mason, and I'm founder and CEO of ConsejoSano, and it's really exciting for me to get a chance to have this conversation with Frankie. As I said, ConsejoSano is a patient engagement, patient navigation company. We typically work with health plans, particularly Medicaid plans, to help them to engage with their multicultural members. We take an approach that allows us to really understand at a cultural level, a deeper level, who that member is, and then to design content that allows us to then reach out to that member and get the member to take certain actions, like bring their baby in for vaccinations or come in for a diabetes screening. So we have built a technology platform that allows us to ingest a lot of data, and that then allows us to micro-segment the larger patient population into much smaller groups that we call cultural cohorts. And then we design the content for the cohort. But all of that technology is really powerful, and I'm really proud of what we built here at ConsejoSano, but none of it has value if it weren't for the care coordinators. Care coordinators at ConsejoSano are the people who actually engage with the patient. They're the ones who help us to design the content and then to actually engage with that patient. And Frankie is one of our star care coordinators, so it's great for me to be able to chat with her and have her really share what it's like to work as a care coordinator at ConsejoSano, and how our work has changed as a result of COVID, so that we are doing more work in the virtual care space. Give me an example of an interaction that you've had in your work with an actual patient where you felt like you really made a difference. I think that'll help people to understand what we do. So give us an example of where you've had an interaction that has really made a difference for a patient.
Sure. Actually, I feel like one of my favorite examples is I worked with a client, a member, and this was with a health plan, and I was calling to sort of welcome them to the health plan. And upon speaking with them, we're going through this like survey, and I'm getting, hey, this is your doctor and all of these things. And they tell me that they didn't receive their package. So, okay, I remember to tick off, okay, make sure to send that to the member. The member tells me their house was set on fire, or they had a fire in their house, so they moved. So, okay, no problem. We updated the address. So towards the end, it's optional to disclose. They disclose to me their culture, their race, ethnicity. And once they got to race and ethnicity, and I was looking at geographically where they were, I was like, I wonder. And they were like, when they were trying to identify themselves, they were like, I'm not white. And like that little bit of hesitance, I was like, okay, they're Haitian. I knew it. I'm going to ask them. I was like, oh, are you Haitian? And we seem to be on like probably from generationally similar. So I was like, are you Haitian? And they're like, yes. And they're like, oh my God. And then we started speaking, and they were able to disclose so much. And I was like, oh, we really have to help this person. I mean, we have to help everybody, but it seemed that this person had so many barriers that we were in contact with the member like on 5 different occasions, because the member was like, I need, how can you help me more? And it ultimately ended up being one of, I think, my personal success stories, because I can relate to that aspect of healthcare personally, as a young adult. He's a younger adult, but as someone in his position when I left healthcare under my parents, and became fully on my own. So it was just an amazing experience, and that's what we all do all the time. So sometimes we're told to, definitely keep track of everything good and bad, but when we have so many good stories that sometimes I'm like, oh, which one do I pick? So
That's great. So the work we do at ConsejoSano, the work that you do, is understanding who people are culturally and connecting with them and trying to build that trust, because we know that trust is a big barrier. Can you talk a little bit about the transition when the pandemic hit? When before the pandemic, we were trying to get people to get into the clinic. Once the pandemic hit, people shouldn't go into the clinic, right? Because
right.
it's not safe. And so we had to shift and really focus on virtual care. So can you talk a little bit about, in your experience, what that transition was like? And you can share any of the interactions you've had.
With the transition to telehealth, uh, well, in the beginning, I would say that I think a lot of people were on board, depending on who we called. But you ultimately see buzzwords, social determinants of health, that happened in real life translate into the virtual space. So I would say that it was a semi-smooth transition, and the aspect that worked was that because of the pandemic, people realized, okay, I don't want to go to the clinic. And so we were able to help them access cares in different ways, right? And I think one of the things that we did really well was tailor telehealth to the patient or the member's needs. So not every member wanted to do or was able to do telehealth via a webcam or virtual visit like this. Some preferred telephone, and so listening and getting that trust from the patient that we are listening to them and that we're taking in account their situations really helped. Because I find that if we were like, if it was just a situation of, hey, I'm just gonna follow this script and try to get you seen, regardless of what your personal situation is, you lost people. Not that anybody did that, but you can tell that that's what they were expecting. But our approach was, tell us what you need so that we can accommodate you. But I have to say that with virtual care, it it's not, it was there, the part about it that I would say wasn't amazing is that not everybody could access it, even if we tried. So we had members who didn't have broadband access, and that's a social determinants of health in and of itself. So that translated into the virtual space. But at the same time, we had members who didn't have anybody to guide them. So one of my favorite examples is I had a coworker. She speaks Vietnamese, and we were just at the beginning of the pandemic, letting this cohort know that they still can keep their insurance while the pandemic was going on, and that they had to re-enroll if they weren't already. Like, there was steps. So this patient didn't speak the language, and told our other coordinator that they they called the county countless of times that they lived in, and wasn't able to get anybody to help them from a cultural perspective, from a language perspective. And our coordinator was able to stay on the line with them and help them sign up online to recertify their insurance. And I think that might not be directly a telehealth visit, but it's just like, to get to the doctor, you must be able to access your insurance. You must be able to access the healthcare. And I found that to be really important, that every step of the way that telehealth is keeping in mind that our population may not, the problems they face in the real world will still translate virtually, and that we have to keep an open mind about that, and that we have to use the information they give us to help them, regardless of, you know, what the means are in terms of course, legal. But yeah.
That's really helpful, because I think, you know, that the idea that the telehealth and virtual care in general can expand access for underserved populations is really important, and we think it's true. And what you've described are some examples of where it's happened, but it doesn't fix everything. Like if that person doesn't, you can offer virtual care, but if the person doesn't have broadband, for instance, they can't do a video visit. We had another instance. I think one of the other care coordinators was talking about a senior population in San Diego County that they don't have email. These are seniors who have never used email, but the virtual visit, in this case, it was a telemedicine solution, required email in order to sign up and actually get access to the portal that where you would go to actually do the telemedicine visit. And I've experienced that myself. I've done these virtual visits, and you do have to have an email. You have to have an email in order to gain access. And so these are barriers that that don't seem important initially. Like, what's an email got to do with the telemedicine visit? But it turns out if you set up the technology so that it requires an email, you are putting some barriers in place. So I think your point is really a good one, that it doesn't solve everything.
Right. And the same people will continuously be left behind,
Right.
And will be left out. And now more than ever, we're using virtual care, especially because we're in this pandemic. You realize that it's not just your geriatric or elderly population that struggle with access. You realize that income inequality and inequities are a part of the conversation. You realize, like, the safety and security, because in this point in time, we see that, for example, robocallers are so sophisticated. They tell you they're calling from the IRS. So now we have an extra job to do to let people know that we are calling from their health plans, and that it doesn't seem like it would be on the forefront because people are not trusting of technology in that way. But it is one of the barriers, and it's something to be addressed as well. That we need to always come from a perspective of human to human, that we're still maintaining, that we're not fully getting into technology, that it becomes automation. And I think that's part of the support with the access, is that it's a balance of a human person with you, helping you, whether it's your doctor or a care coordinator, and the technology. So combining those two is also something key to have on the forefront of things to be mindful of.
It's a very insightful point. It'll make a lot of people, a lot of venture capital investors unhappy, because what they want is are solutions that take the human out of it, because it's cheaper and it's easier if you can find a solution that completely removes the human. And it's all automated, and that's a true sort of SaaS solution. But what you're saying is from your experience that that those kind of solutions probably aren't going to be that successful in healthcare. If you try to take the human completely out of it, that's probably not the best way to build trust and to get people to engage, especially people that struggle to engage and have trust issues.
Right. I mean, we're not there yet with the AI, I know people would be upset if Siri took their job, but I, yeah, from my perspective, it's super critical because, in fact, when people think I'm calling and they're expecting some sort of automation, they're immediately angry. I come to them, I come to them with a soft tone and just like, hey, I'm here to talk to you about your healthcare. I'm not here to get any information other than your zip code so I can help you in your specific area or to verify. But um, I realized that with myself, even outside of that component, when you go to, when I've gone to a doctor and the doctor is not very is maybe a little bit cold. It's just like that translated. If someone's cold to you in real life, you're definitely not going to want a robot to correspond with about your healthcare. You know, I mean, many of us spend a lot of time on the phone going, representative, please, right? You know, it's because we don't want to deal with pressing one or having to, and we want that care that's tailored to us. Like, I have a specific question and nothing on your sheet can help me. So I think it's really important that we keep that in mind when we're going forward with technology and how we sort of code that.
That's great. I don't know if you have a specific comment on this, but I know when we first started to when the pandemic hit and we had to work with our clients, particularly federally qualified health centers, or these other clinics that are the safety net providers, they used to get paid because a patient came into the clinic, and that triggered the payment. The patient had to step across the threshold and see a doctor, and that would get the clinic paid. So when the pandemic hit and we had to keep people out of the clinic, a lot of these safety net providers, their revenue was reduced by 90% in some cases. They were in danger of closing their doors, and we were really fearful that once you lose a clinic like that in these neighborhoods, you might never get it back. So protecting that safety net was very important. So we shifted our work and started to really encourage the patients to use telehealth or to use virtual visits. Now, the clinics had not before done virtual visits because they couldn't get paid for that. As I said, the patient had to walk in the clinic, but because of the pandemic, the regulations changed. And so the clinics, these safety net providers, these federally qualified health centers could get paid via a virtual visit, but they had never done virtual visits, the clinic, and the patients had never done virtual visits. And so one of the questions was, can you get folks who are multicultural and low income? We do a lot of Medicaid work. So they're low income, low health literacy. They have trust issues. Can you get them to do a virtual visit, something they've never done before? And as you know, because of you and the rest of the team, we were able over 3-4 months to, I think, generate about 50,000 virtual visits. But here's my question. Were you surprised that low income and low health literacy and multicultural, and there are a whole lot of reasons why you would think people who for whom all that is true would not be quick to use a virtual visit, but it turns out we were able to do it by the tens of thousands. One, did it surprise you? And two, why do you think you were able and your colleagues were able to get people to do something they had never done before? They had never done this.
Well, I would say that I was actually a little bit surprised, but in that same vein, I wasn't, because with the virtual care, I realized that we kind of eliminated certain SDOA, certain social determinants, right? Someone didn't have to physically take transportation to go to a clinic that might be in an unfavorable area. And so when we took that away and we said, and they were aware that, oh, okay, the doctor's going to be on the other end, and if sometimes they had a family member with them, they're like, oh, that person's helping me. But apart from those little outliers, these you saw that it worked again, because they were able to see a doctor, something that they might have not been able to because of convenience as well. You know, I encountered a situation where a patient was living in a rural part of their state, and I was surprised to see how welcoming they were of the virtual care of telehealth. They said, "Oh, I loved it. The doctor was nice, and I was able to get certain questions answered, and I didn't have to. That I would have had trouble because I'm actually 50 or so miles away from the clinic because they're rural." And
Right.
so with that, it was like, wow, we are really on the flip side, what I've just told you, but it works on the other way, that we were able to access people more. Like earlier, I was saying, yeah, that it was hard because of the social determinants of health that follows the patient virtually, but you have eliminated some of those social barriers, um, primarily transportation, crime, and convenience. You know, they'll say, "Oh yeah, my doctor was much more understanding of the certain times, and the visits were not as long, of course, because they're not being examined necessarily." But yeah, when I talked to this elderly man, and he was like, "Yeah, I live 50 or so miles away from my clinic. I live on top of a mountain, but I think they had broadband access
Mhm.
because they were so remote. But they were like, it was much easier to talk to my doctor and not have to. And this person is also not, you know, economic feeling economically sound. So they were like, it takes a lot of gas to put in my truck to drive all the way to the clinic, which is 50 miles or so away. And so this person tells me they usually wait until things get really bad, and that's what we know, right? So I find that the virtual care is perfect for preventative care and preventative urgent care. Just being able to talk to your doctor and say, "I have these concerns." If you can't address them virtually, then they have to go in, but being able to do that and not waste that trip.
I mean, that's a really powerful story because for that particular man, there was a whole host of barriers to him accessing care if it had to be in person. The distance, the gas, the time, very complicated, and putting in place a solution that allowed him to, or offering him a solution that allowed him to get care much more easily. I think that's really kind of the big opportunity that virtual care offers for low income and underserved communities. I think it's a great story, and I'm sure it happens time and time again. I think the challenge is how do we and this is not for you and me, but this is a policy issue. Part of the reason we were able to do what in fact, I shouldn't say part, the whole reason we were able to generate 50,000 telehealth visits for FQHCs was because the regulations at the federal level, and the state has a role in this, they changed the regulation and they allowed the clinic to get paid for that telehealth visit. Whereas before the pandemic and the old regulation was in place, the clinic couldn't get paid for that visit. And so therefore, it didn't make sense for them to do it. So I think one of the big questions going forward is the rules and regulations that have been changed in order to make it easier to access healthcare during the pandemic. Are we going to see those old rules put back into place and to create those? We've reduced the barriers, and now once the pandemic subsides, are those barriers going to come back up, and we're going to go back to the old way of doing things, which means that those clinics won't be able to provide a virtual visit. I know it's not a solution. You and I don't control the policy, but I think it's it's one of those big issues that we confront now, because we've learned that when you reduce the barriers, which is what happens when you remove those old regulations, it creates new access for patients, as you've described.
Right. But something, I think, like, I think we won't be going back personally. There might be a push to, because maybe I wouldn't, I don't know too much about this in this with the regulations, these certain aspects, but like if we are now seeing numbers like what we've seen, and that's just us, right?
Right.
how how could any um any policymaker say, well, what's a good idea for us to regress, and I think we'll have to find a balance. Probably there won't be as much leeway, or as much it won't be um the way it is now, and we're in a certain circumstance. But the aspect of being able to outreach and engage with patients who I've actually engaged with people who have not engaged with healthcare. This pandemic has brought that out. And so you've got to take a look into that and go, well, that's interesting. That's important for us to use going forward. It may not be what we want in terms of what it is right now or what it was, but a happy medium of definitely giving the clinics the ability and the access can empower the clinics to become more involved in the healthcare of their patients if they're able to do it easily. We want to be able to make things easier, not just for the members, but for the clinics as well, because that way we'll be able to cast a wide net and help as many people as we can. Because I think that's what virtual care has been able to do, and not just with cameras, again, not just the telemedicine face or video timing, but telemedicine through the phone or online, or just the many ways, just making sure
Yeah.
that we're able to do that. Yeah. So
I want to address that issue. You brought it up, and I think it's a really important issue that you brought up. There is this kind of view when it comes to virtual visits that video visits, sort of like what we're doing now, is like the platinum solution. And if you just have a call with no video, it's somehow like the stepchild that's not wanted. It's like that you've got this great solution here, and the phone is not a great solution. And what's happened is, in the past and even now, the reimbursement, the payment is different. They pay more for a video visit. The government does when you're dealing with the government programs like Medicaid. Than they do for a phone visit. And so I guess I'm going to tell you my opinion, but I want your opinion. I think that we should move to a more consumer centric approach, and that we should let the patient decide how they want to communicate. And the patient prefers to use the phone, sometimes because they don't have broadband maybe, but sometimes they might just prefer to use the phone. For instance, I've talked to some other care coordinators who said that when it comes to mental health services, a lot of times people are more comfortable talking about mental health and talking to a therapist on the phone versus video. In fact, they won't do the video, but they will do a phone. So my point is, number one, I think that we should be more patient centric and treat the patient like a consumer, and let the patient decide how they want to communicate, and not price it differently. Because if you pay differently, the system is going to get shifted toward what produces more revenue. And so that differential is really a problem. So I guess my question for you is, one, you don't have to agree with me, so you feel free to disagree, but do you agree that we should really be more patient focused and let the patient decide? And that's one thing. And two, what's been it sounds like your experience has been that some people prefer the phone. That's what they prefer, and we should accommodate that.
I couldn't agree with you more. And in fact, I think it's a good point you make. We should make it more patient centric. Also, pricing it differently gives different people disadvantages, because I think a lot of people would prefer to talk on the phone, also to remain anonymous. But in the same vein, if I want to do telehealth, maybe again, I'm 50 miles away from a clinic and I have maybe some sort of a rash. If I'm able to visibly show you that, if I have the option of doing telehealth with a camera, and I'm not worried about, the payment structure of that, I'm more comfortable with the idea of talking to my doctor face to face. Look at what I have here, something like that. But at the same time, if I want to talk to my doctor and there's maybe not any physical symptoms, or I know if you're a younger person, and then you have something uh, personal you don't want your parents to know,
Right.
you might want to talk to your doctor on the phone because you're scared of the doctor sees you and you're
Right.
like, Lord. um, but I think it's important that we empower, of course, people to make the decision of how they want to engage um, with their healthcare providers. And I couldn't, yeah, like I said, I couldn't agree more. And yeah, I find that even though we do now, people are able to access the camera, they still prefer the phones. It's more convenient because a lot of people don't have, a lot of people will be able to do their appointments while doing errands or doing other things.
Right.
And you really can't multitask when you're on camera.
Right.
Um,
Right.
Especially during a doctor's visit. So, there is that. But I think you, and and it runs generationally too. There might be a group that will prefer video, but I think even across the board, most people prefer the phone. It's quicker, you
Right.
know, less awkward sometimes, depending on who you are.
Well, that's the other thing. I did a video visit, a video chat myself, and I'm not a technologist, but I'm pretty good. And I actually had, it was not easy to get on the portal that my doctor uses to do video conferencing. It was like 8 steps, whereas if you call, it's like one step. And
Right.
so, and I was with my sister. She shared the same experience that doing a video visit was much more complicated. So that says to me two things. One, maybe the reason people prefer phone now is that we haven't, from a technology perspective, made video conferencing as easy as it should be. It's just not easy, especially if you use these more sophisticated portals that people used to have to use. Now the regulations relaxed a bit, and you can use you can use Zoom, which is a little easier. But if we go back to having more secure, quote, secure video chatting, it's very complicated and it takes many steps. So I think that's one factor why people prefer the phone. I think another factor that's just important that you bring up, and I think we just need to reemphasize it, is that broadband is just not available to everyone. So not everyone has the ability to do that, and we need to take that into account. Um, have you had any personal experiences or someone you know with like video visits or virtual visits?
Yeah, I personally haven't. I'm very much not scared of technology as I work. I can't say that, but no, I haven't yet. But I have encountered people who have, and the the video visit they had was, according to them, very short and very sweet, because this happened during, like, probably around June, during the, like, in the earlier, mid to earlier part of the pandemic. And they said they really really loved using the video feature, because this was actually with their therapist. Speaking of, this person now is in their own outlier, but they did enjoy it, and they have a rapport with their therapist. So I think when they were able to access this therapy from the comfort of their home, I think they told me they were able to sort of go deeper with their therapist, and sort of be able to, like, sort of absorb more without the distraction of like, oh, I'm at this place and I have to be somewhere and all of this. So they actually liked it. And it sort of made me go, I guess I should try it out when I have a doctor's visit. I have other friends who, not necessarily video, but who recently they went to an urgent care, and they said the nurse texted them, and they were like, it was so fast and easy. So, even the texting part, I don't think that it'll be as much as phone and video, because it's just so much you'll have to text to be like, on my left side under my arm, you know. But I definitely I've heard definitely good things about the video. But from our patients, I actually heard like one patient go, oh, it was too short, I didn't really understand, and things were cutting on and off,
Yeah.
typical technology
Yeah.
barriers like you had. And
Yeah.
so I foresee that I probably align with you on that. If it's too many steps, just give me a call.
So I know I don't want to take all your time, but one other question is, so uh, why do you do this work? Because you're not, I mean, because your work has always been virtual, right? Even when you were before the pandemic, you were trying to reach out to a patient and get them to go into a clinic. During the pandemic, you're trying to reach out to a patient, get them to do a telehealth visit. Maybe when the pandemic is over, it'll be a combination of the two. I don't think we're going to swing back to where we were, where all visits are in person. I think after the pandemic is over, I think we're going to probably settle somewhere where there'll be a huge percentage of visits will remain virtual, although we'll probably have more in person than we do now. So, we won't swing back to where we were, but somewhere in the middle. But the work that you do as a care coordinator is actually is sort of the same, whether you're trying to get someone to go into the clinic and help and reduce barriers and build a relationship so they'll tell you what's happening and you can navigate them in, or whether you're trying to get them to trust you so that they will use a virtual solution. Either way, you're doing similar work. So my question, I guess, is why do you do this? Because it's not easy work to do, and you're sometimes often talking with people who are struggling, and it's a difficult moment for them. And so why do you do it?
I think that's exactly why. And I'll tell you this. I will begin with this. I myself, when I became, when I had my own insure, or I had to go to the doctor but on my own, when I moved to a different state away from my family. I was still under my parents' plan, but I was having to make my own appointment. And I had a nurse who told me about an immunization card that I had to have, or she was like, oh, do you have it? And she sort of berated me and was like, looked down upon me. She was like, you don't have this card. And when I got in cahoots with you guys, involved with ConsejoSano, and health and patient care and language, I wanted to use, I came here to use my language to help people uh, of my culture and of all cultures and all people who are sort of not associated with their health because of their culture, because it's too hard. And so I originally came because I wanted to do that. And then the beginning of the pandemic happened, and I was like, oh, what's more for me to do that I can, reach for the stars? And then we get a client who says, okay, you're going to call these people and see if they need any help um, making an appointment. And I called this cohort in San Diego, and I found myself encountering Haitians, and I was like, in San Diego. And also when I call them, I see the name. I don't approach them automatically in Creole, but I see the name. I'm like, okay, Haitian, but I'm going to say hello in English, and then I'm going to say hello to them in Creole. And then as soon as I talk to them in Creole, I find out that they were not able to access their healthcare because of the language barrier. And so in this instant, when the first time I reached a San Diego patient, we made an appointment, and I said, don't forget your yellow card. And they're like, yes. And they hadn't brought it either. And I remember that. So I guess I told the story backwards. I was in this situation where this patient had this yellow card, and it reminded me of my own situation. I was like, okay, don't forget that. And then time and time again, I'm like, I feel like it's a responsibility. Like I wanted to say, like, you know, in Spider-Man, when Peter Parker's, was it Uncle Ben says, you know, your powers are a responsibility. I'm not saying that I have any powers, but I speak a language that is not like super accessible everywhere. Unless you're in certain parts of certain states, you might be able to get a translation. But it's that was the seed that sprouted into me wanting to go further into engaging patients of all cultures and wanting to make sure that they were heard, and that they know that their healthcare is important, and that it's not just, have you gone to the doctor, okay, whatever, bye bye, never to speak to you again. And that we follow through with them, and that we make sure we take the steps to gain their trust, so that we can in turn use it to help them and other people, which is very important, because we learn every time I talk to a patient, I learn how to engage a different patient.
Um, that's that's really that's wonderful. Well, I can tell you, we are glad to have you at
I'm happy to be
ConsejoSano.
here.
And I, you know, I think we all share this mission. We want to create a healthcare system that works for everybody who calls this country home. But we're not going to do that if we expect people to be different than they are to get healthcare. What we've
Yeah.
got to do is that we have got to change and be more inclusive and figure out how to engage with people. And what you've described is exactly what we need to do. And so I just want to thank you for having the heart to do this work,
No,
because
thank
it's
you for
important
having me.
work.
And might
Yeah,
I add that it like, I want to sort of echo your sentiments. It is because it is what makes any part of the healthcare system that I find here to be the best part, is the part of the healthcare system that engages with people on their level,
right,
no matter who they are.
right,
And I find that you can go to other um, countries, or you know, between clinics within the same state or within the United States, and the ones that do it right meet patients at their needs,
right.
address them with trust. And it's so important, because again, at the end of the day, you can't say, like, if someone tells you, um, I don't have a ride to the clinic, I'm gonna be 15 minutes late. Well, sir, you know that our policy is X, Y, and Z. And it's like, then they're not gonna come back, you
Right,
know?
right,
So you need to use that information to sort of, you know, create like a plan for them. Maybe it might be too, we don't wanna get too specific with every person, but we need to come up with ways that we tell people, whatever barrier you have, we can at least address a resource to help you get there. Even if the clinic can't provide you a ride, or your plan can't provide you a ride, the plan should be able to, or the clinic should be able to have resources that are government or non-government, to say, hey, have you tried this? Or, you know, just talking to the patient and see what needs need to be met before their needs of healthcare can be met.
couldn't agree more. And I'm just glad that we have people like you committed to this work. So thank you for taking the time, Frankie, and
Thank
glad to
you.
have you on the team.
I'm so happy to be here, and I'm so happy to work with you guys, especially you too, Abner.
Thanks.
Thank you.
Thanks very much.
Thank you for joining me and watching our video on equity in virtual care. I hope you leave with a new perspective on how virtual care has the potential to improve access to care for all of us if policies and practices are approached the right way. I invite you to join United States of Care to be part of the solution in creating a virtual care system that works for all of us. Please like our video, leave a comment, or email us through our website at unitedstatesofcare.org.